Hello everyone. To all ISGE members all around the world, this is Dr. Tamer Secki in Sao Paulo, Brazil. I am reporting from the joint Brazilian and ISGE endometriosis meeting. We had the pleasure of having you today, Dr. Yves Leroy from Mexico City, who will be informing about his valuable techniques on myomectomy. Yves, how are you today?
Fine,
nice
thank
seeing
you.
you. I have specific questions to you. You have talked about myomectomy, and I'd like to tell our viewers what are the indications for myomectomy surgery, and what are the challenges, and how you deal with it in your environment with those challenges.
Okay, and there are many ways to treat myomas, and it depends very much in what you want to achieve. Like if that person wants to keep her uterus for reproduction, or whatever the idea, she wants to conserve the uterus to keep it, so the technique of myomectomy will change. And myomectomy is the surgical procedure, but there are other non-surgical procedures as well.
At this meeting, obviously, we are talking about the surgical laparoscopic management of the myomectomy. How do you stitch the uterus back, and what are your criteria of cavity entrance or not? What makes a difference? Does it make any difference with the way you stitch the uterus back? And how do you remove the specimens?
Okay, and first of all, you have to make a plan of, you have to plan your surgery, how many myomas, the location, and the sizes. And then you can plan the surgery as far as time. And if you don't have good instruments, you don't do that kind of surgery. But and to begin with, we incise the place where the myoma is, and we infiltrate with pitocin. Then we start doing what's called enucleation, and we're trying not to remove any tissue which is not damaged. So we go directly to the myoma, and we use very much the technique of enucleation by going around the myoma once where the myoma is free to come out. So we leave it there on the cul-de-sac, and we go to after the next one. And on doing that, the number of myomas would be 3 to 4 or 5, and then we start the suturing process once we have mostly all the myomas out.
And lastly, how do you remove them from the cavity, from the abdominal cavity?
It's very useful to have
Morcellator?
a morcellator, and usually the morcellator has to be electric morcellator, automatic. Otherwise, it will take you a lot of time.
Do you use cul-de-sac? Do you utilize cul-de-sac?
Sometimes at the beginning, we used to go through the cul-de-sac vaginally and remove the big myomas. Anyway, morcellation is the key of reducing operative time. If you do that, and you will finish ending the surgery by removing, this is the last step of it, is the use of that morcellator. The closing of the layers has to be in at least 2 layers. The myometrium has to be closed properly. And this is the most difficult part of it. That's why the surgeon has to be skillful about suturing. Otherwise, it will take a long time to do it.
Thank you for your time, Dr. Yves Leroy.
Okay, thank you very much.